and I will for a little bit, but you can stop me anytime. In fact, I might stop periodically, so you can, prompt you through very pregnant pauses to like ask or interject things. As Sarah pointed out, I am here for very selfish reasons. I mean, I think I have really enjoyed working with people on this campus, and I'm going to show you that we've been working also in the environmental exposure space for a couple of years. Some of my students, my PhD students, have been working in that same space.
Do you mind speaking up?
Sure, but I'm happy and I'd be thrilled to do more work with folks on this campus. Now, I am not going to talk about AI at all, just to be clear. Even though we just recently launched this new Northwestern Network for Collaborative Intelligence, I'm not going to talk about it because I think it's not yet relevant for the type of stuff that we're doing with folks here now. So let me just ask you all, what do you guys think about population? How do you think people currently measure the health of people in the city of Chicago, like public health, Illinois Department of Public Health? How do you think people get measurements about like who's got diseases and who's got, whatever? What do you think people do today?
The morgue.
The morgue. So all right. So death certificates are but death certificates are funny because death certificates are very skewed. They're like, and the dirty secret of death certificate, they're terrible because when you're trained in medical school, there's all these things you can't say on death certificates. And so you have to like come up with some sort of like chain of things that happened. So you can't say heart stopped, a heart attack, can't do it. And so there's a lot of things that are hidden in there that just will never show up. So, but it's a good place to find the ultimate sort of like outcome. Other things. Jeff? Wastewater. We're going to talk about that. That's a huge, huge thing and becoming more and more. And that is sort of the punchline in many ways for how we're going to work with you all going forward. Anybody else have any ideas how we do it? Yeah.
Missed workdays?
Missed workdays. Okay, I love this. So what I like about this is that you're all thinking about different ways of measuring health. And the unfortunate reality is that today, let me see if I can advance these slides without, okay, anytime I do talks, I have to give a required disclosures. So I did it. I'll just skip past this. All right, so this is how we currently measure the health of the population. People get on a call and they call landlines. And this happens all across the country. 400,000 people answer calls every year. And the big innovation a couple years ago was this. We went from landlines to cell phones. Now, anybody have any idea what that might do in terms of actually measuring health outcomes? How do you think this does? Anybody here in politics or do polling or things like that? What do you think happens there? Probably not great, right? I mean, how many here, if you got, first of all, how many people have a landline? Okay, so we're down to 2. All right, everyone's got a cell phone. Who picks up, I'm not gonna go pick up the landline people. Who picks up when you see a number you don't even recognize? It comes in from especially today, if the Census Bureau calls you, are you gonna pick up? Nobody picks up, but you might. Okay, so we have one person in this whole group of people. And we're going to base our estimates of the health of our population based on your response. And we take that, and in the city of Chicago or state of Illinois, we have our own, this is called the Behavioral Risk Factor Surveillance System. And this is used nationally, 400,000. We then oversample. We basically take in Illinois and in Chicago in certain jurisdictions, we say, all right, let's go ahead and call up this number of landlines. And from that, we then take the responses and we extrapolate. We basically interpolate that out across the whole population and say, this person answered, they're of this demographic. We're going to say that everybody with this demographic had this set of conditions. It's really a really hopeless system, but that's the best we have. Now, this is the kind of questions that are asked. So, these are the categories. This is just pulled off the website last night, because I just don't prepare for things until the night before. And then if these are the types of questions that we ask, and so we not only do we only ask a few people, we only ask them these questions. So there's a handful of conditions that have to map to one of these things, and in the chronic conditions, they might ask questions like, have you ever been told by a health professional if you've had a heart attack, or if you've had diabetes or a stroke or asthma? Now that's really limiting further because now you only have things that people know in lay terms and recognize they've had. So if I ask somebody, have you ever been told you have diabetes? People might not remember it by that, but if someone asks, Have you ever been told you have high blood sugar? They might, oh yeah, I was told that. And so again, totally not like accurate. So what we've been trying to do, and this is it seems so obvious, like, is we've been trying to find ways to use data collected through routine clinical care, like when we see patients, and can we use that to identify the population prevalence of certain conditions? And so we've been doing this, and it seems like it should be totally obvious, but it turns out not many people have been doing this for very long. The people that really pioneered this were in New York City. So when we first started this project back in 2008, a couple of us, including some folks from public health department here, we all flew to New York City. We went and met a couple folks there, the epidemiologists, and we sort of sat and watched them. And we said, we can do that in Chicago too. And we've been trying ever since. And the goal was that if we wove together data from across different health systems in Chicago, we would go ahead and get a much more complete picture of what's going on with the health of the city. And we could create maps like this. Has anyone ever used the Chicago Health Atlas? You know what that is? Okay, you've used it. So the Health Atlas is, you may not know this, but we actually created the Health Atlas before it was the Health Atlas. My group did. And we had Sprague Foundation funding, and we had pulled EHR data back then. But we ended up in sort of like a weird political battle, and we didn't release it because we thought it might get misinterpreted, EHR data. We didn't have all the weights and all that kind of stuff. We didn't release it. So the end result, it went through a bunch of iterations. The current version you see today on the website is still using primarily survey data. So that thing I showed you with the phones, that kind of stuff, that's still the standard by which we measure the health in the city of Chicago. So we figured out that if we took the catchments and took every single major hospital system in Chicago and we pulled all their data, it was a crazy idea. We said, University of Chicago and UIC and Rush, hey, I got this great idea. You give us all your data and we'll give it back to you in some usable format. And it kind of worked because of things like this. We all met, we got pizza, we talked, we got along with each other, and we decided we're gonna go ahead and do this thing, and we did it. And then we added a bunch of governance later, and it became something that was really pretty powerful. It actually got us pretty high saturation over the catchment. And if you imagine each time you go to the doctor, that's in many ways like a sample. It is a sample of a person's health. It's like a survey. In fact, it is like a survey. When you go to the doctor, the guy's like, hey, how you doing? What's going on? What's affecting you? But you capture not just the questions that you ask, but anything that was measured by anywhere in the health system. So now you've got this much more broad perspective. Yeah?
How does this data, so I think when you ask a question, you should say your name, department. Sarah Young, anthropology.
Yeah.
Co-director of Center for. How does this data saturation compare to what other cities have? Like,
most places don't have this. And this is why I'm trying to pitch this to you all. I am selfishly here because I want you guys to use this data resource as other people on this campus and public health are currently using and paying for. So a lot of our funding right now is coming from public health because they also recognize that the survey system is kind of dumb. And so now they're saying, let's use your data. But, and this is the part maybe I need to turn this off for, it's a little controversial because public health is one use. We are a research and education institution. So we have had to be very careful in navigating the nuance of what these data are used for and what they mean. Yeah, go ahead, sorry.
So I'm Aaron Paxton, Civil Environmental Engineering, also co-director of
Oh, nice, easy, yeah.
So the question I have, how do you define a catchment?
So we don't define the catchment. The health system, when they send us all their data, we map it all, that gives us their catchment. So they may not even know their catchment until they give us their data and then we give it back to them.
But that's based on like people that are going to particular hospitals.
That's correct, which is why it's so fragmented. If you go back and look, like I know which hospitals these are, but like, you know, you can probably guess which ones they are, but where it's dark, that's where the most concentration of patients come from for that health system. But again, you can see why there's a problem because if I wanted to know what the prevalence of diabetes is in Chicago and I just have Northwestern's data, I'm going to have a pretty good sense of who lives in Streeterville, you know, and well-insured neighborhoods. I'm probably going to miss big swath of the city. And so this compensates for it by weaving it all together. And in order to weave it together, we had to create a new technical resource. We actually had to find a way to link data across institutions in a way that preserved privacy. And that was actually a whole technical journey that led to some of our conflicts of interest, where we created a company, we built software, the software got acquired by a different company, which now rather inconveniently sells our software back to us, which is not the best outcome in the world, but you sometimes take a few hits along the way. The other thing I was going to say, though, is that these data are still, there's a little bit of bias to them, right? So like, if you think about who goes to a health system and receives regular care, all right, I'm going to call some people out here. All right, how many people have seen a doctor in the past 6 months?
Are you saying it's all the old people?
No. So, okay, the young men in this group, how often do you see a doctor?
Every day.
Okay, you're dead. Okay, all right. Okay, fair point. How many people see a non-family member for it? Once a year. Okay, all right. That's actually surprising. So, okay, I'll be the first to confess. I'm a primary care doctor. I didn't get my own primary care doctor until this past year. All right. So, because what we do in our practice, we all go, hey, I need a lab. Can you order it for me? And we all just like cover each other. So that's how it works in healthcare. But the reality, and what this shows is that this is EHR data on the red side. And again, we called it Health Atlas initially. What you see is that people, especially young men, almost never come into healthcare unless they've done something like traumatic, dumb, or it's a particular part of their anatomy. They don't come in. And that is the reality of healthcare in this country. And so, knowing that, we recognize the limitations of the data we have. But what we figured out is, much like any survey, you can adjust the sample. So if you treat this as a survey, you can weight essentially people coming in and adjust accordingly. But now, instead of a sample of, like 20 within a geographic region, you have, 400,000. That is a much different sampling rate than if you had just done it by survey. So this is all like, great. So what we've done now over the past, I don't know, sorry, I can't do it turning around. Since 2008, we built this network. And this is the thing I'm trying to pitch to you. So this CAPRICORN network stands for Chicago Area Patient-Centered Outcomes Research Network. It's run out of Northwestern, out of my group. These are all the institutions that contribute data to this network now. We have a bunch of stuff built around it. We just added Sinai Chicago, which I'm super proud of, because the folks at Sinai Urban Health Institute, were pioneers in the health of cities. They actually did surveys, the first surveys of Chicago, and they were the first ones to establish sort of how you could use survey methodology to understand the health of populations. And what you'll see is that many of these groups serve underserved populations, which is fantastic. Sorry, go ahead.
Alex,
Yeah.
material science and public health.
Yeah.
Do you extend to, I guess, a lot of hospitals here? Do you also
Yes.
work with smaller clinics in rural
Yes.
areas across the state? How's the access to
Yes.
those?
So we work with many of the small clinics. Even before this project, I was helping to install electronic health records throughout the city of Chicago with federal funding. And so we knew every single one of the FQHCs. As part of this project I'll show you in a second, we're adding on a lot of the small clinics like Lawndale Health and TCA. All the small clinics we're adding in as well right now. There are some limitations because it takes some work to get your data in order. But we've got some additional funding to help us sort of onboard these smaller clinics. But great question. I think it's really an important population, and that's the most vulnerable people are often the ones that we don't get. Recently we went through this a retreat, and we said, what do we really want to do with this network? And across the board, these are the three things we said we're going to do: population health, health equity, and technical innovation. Those are our three pillars. And every project that comes to us, we say, does it satisfy at least one or more of these pillars? And the other thing is that, and these are I hate using words, but maybe these are worth mentioning. There's a lot of work under the hood. So I've got an administrative team. We have a steering committee that meets once a month. We have an IRB. If people have ever used IRBs, we hate them. But this is a really good IRB. This IRB we've got it optimized. So if you send a de-identified data request, we turn it around within a day. It's faster than our own organizations. We have data use agreements in place, which took 2 years to ink, but now we've got it standardized. We've got a recharge model. What that means, you go to one place, you get an IRB, you get a contract with one institution, and then we distribute the money along a standard rate. So we have a standard project management rate, standard data rate. Everything is standardized for efficiency, because we are like the university. We get our money from federal grants or from public health or what have you. So it's in our best interest to reduce our costs so that we can maintain a sustainable organization. So we try to keep the cost down as much as humanly possible. So, all right. Just for people to understand how, so when you go to a hospital system, this is Northwestern, a typical flow is you get seen by the person in clinic, your data goes into EHR. Every night we load it into the data warehouse. It then goes into a data mart. That data mart is standardized, and every single institution has the same flow flowing to it. So this federated model allows data to be flowing in standardized across all these different institutions. This is an example of a project we're working on right now that was initially going to be funded by ARPA-H until ARPA-H, the federal agencies decided that people living in the south side of Chicago are not a priority of the administration, and they cut the whole program across the whole country. It's pretty bad, actually. But what this is to show you is that using CAPRICORN data, we can measure the atherosclerotic cardiovascular disease risk for the whole population in the city of Chicago. You can see how there's been a trend line over the past couple of years. And then if you go ahead and map it by zip codes, you can see there's dramatic shifts. And people have known this about Chicago. We have like one of the biggest life expectancy gaps in the country. And it's because of things like this, chronic diseases. So if you look at, actually half of it because of chronic disease, if you look at the most recent public health report. So, we've got like people living in certain places where their ASCVD risk score is like under 6%. You go somewhere else and it's almost 14%. That's a huge, huge risk. That's your 10-year risk of having a heart attack, stroke, or dying. And so this accounts for at least half of the increased, like a reduction in life expectancy across the city of Chicago. All right, so these are, and if you map it, every map of Chicago from a health standpoint looks exactly like this. Every single one of them, which is why, what we're working on now is not mapping it only. We are now working with a marketing for public good company who's offered pro bono support to go ahead and help do targeted marketing in the Chicago media to help us reduce ASCVD risk, which is the thing I'm super excited about and AMA is excited about. I'm going to skip ahead real quick to something else. This was just to say that we've done work linking our data to other sources like homelessness data. Punchline, giving people homes reduces unnecessary use of the health system. That's it, all right? But again, obvious, but it's nice to be able to measure it. These are people I love working with, and they're all here in Evanston. So one of the joys of this new role is I get to come up here, and I have an office across the street now, and I can be like, hey, meet people for lunch. And I got to say, by the way, your campus is way better than the Chicago campus. It's where the pace is much nicer. It's very chill. It's really great. Public health has given us some funding, and they work with us to measure sort of health of populations. I just met Dan just before this. We talked about some of our students we share in common. And Dan's been doing a lot of work with diffusing disasters, climate effects. Terry Sabel just got her data use agreement in place with Chicago Public Schools. So we can link CPS data now with our CAPRICORN data to understand the effects of school policies on health outcomes for kids. That's pretty exciting. And so that was one that we've been waiting for a long time to come through. And then Jenny and Shao, I just bring them up because I've worked with them for 10 years now. Yeah, Jennifer.
Jennifer, I'm from biological engineering. So does any of this data help us link environmental quality to health outcomes? So like air pollution events, water pollution events?
Yeah, that's exactly what we're doing. So let me show you. This is a great picture of Dan looking really like oomph, like got oomph there. And so he was, he's been fantastic. We actually co-mentor students together. Peter Graff, and we just graduated one together. And I took out the map. There was a map that basically shows heat vulnerability index in Chicago, and that was the same thing. We link. So you can link things in a couple different ways. You can link by person, place, and time. And it turns out pollutant exposure, you can, and our students have already pulled this together, we have data sets that have the accumulated exposure or even daily exposures for various things. Heat, humidity, pollutants, all broken down into 1 kilometer square rasters that you can then map back to people's home addresses, and you can create a cumulative exposure. And as I was telling Stira earlier, one of my students who just graduated is now taking that to extrapolate out and use that to using exposures to nitrogen dioxide as a predictor of outcomes in ICU and showing amazing results. So the health of a person is not just what we see in the health system. It's all this accumulation of things outside the health, which makes total sense.
So base this only on person's home address, or do you include some human mobility?
We only have a home address right now. But you're right, people move around a lot, although arguably the large majority is probably where they live, but it's a fair point, yeah. But that's actually, that's a problem, but that's actually where the opportunity is. And so the real reason I'm here is because of this. Like, we have been working now on linking data to health on the air side, right? But I'm pretty sure people here know something about water, and we get exposed, we are mostly water, like we take it in, we drink it, we expose it, we swim it, I don't know what we do with it. But like, and one of the biggest success stories of this was with COVID. So it used to be that COVID, we were like, well, we gotta get all the labs from all these different systems, we gotta go ahead and I remember early days in COVID, I was like, I took my whole team, and because I didn't want to end up on the wards seeing patients with respirators all the time, I was like, I'm going to be useful. And so my whole team became like a data monging sort of group, and we helped pull data from all across the state, from emergency departments and health labs, and we aggregated it and we sent it to IDPH, and we were the first folks who built the dashboard for IDPH back in the first COVID days. And that was my team, and we were all like, you know, we got a lot of political capital for that, which was nice, and they have given us access to data sets since, which has been nice. But what that has led to instead, that didn't work out as well as I said. It was too labor intensive. And so now what happens is people use wastewater. And so what they do is they basically, we know the catch. Okay, you guys can tell me how this works. I don't understand it. As best I can tell, toilets are like an underground street system, and you can kind of tell who went number 1 and 2 in some part of the city cumulatively over time. Is that fair to say?
I mean, I really like the analogy.
So I don't know. I mean, so there's a guy from water reclamation across the street from me, and he's like, I don't know. We were talking the other day, and he's like, yeah, this is how it goes.
You can map catchments. That's why I asked about catchments. So you can
Yeah.
map sewer catchments.
Yes.
That's how it's done.
Right. And I.
Population contributing to a place.
Yes, and that's what they're using. And so what they do is they now come up and they say, like, they give, CDC does this across the whole country, and they say, you know what, like COVID is, where it's dark, there's a lot of COVID going on right now. And so, and we do the same thing here in Illinois, and it's not us, it's IDPH, it's these folks over at the Discovery Partners Institute, who, by the way, are very interested in pollution stuff. So we meet every month, actually, as a group, and we talk about our work on pollution right now. But nobody's mentioned water yet, but we could start working on that. So again, this is why I am here. There are these different like monitoring stations, and what we can do, or the folks at DPI and actually UIC are doing, is when they get the wastewater, they do this blast sequencing. They basically sequence the crap out of it. And it takes a long time, a lot of compute, and they can figure out, okay, there's this amount of like infection coming from this part of the country. And so if you wanted to see what the next measles outbreak might be, you'd go, hey, let's look at this. And you could detect that there's something bad out there based on the DNA sequencing in the toilets, basically.
Getting back to your
Yeah,
point
yeah.
years ago.
Yeah.
Al, can you please introduce yourself?
Oh, Alan from Material Street Research. Years ago, probably back in the 90s, New York City determined that when the weather came on at night,
Yep.
10 o'clock news, those that had the earlier shots, there was more flushings. So they were taking the flushings about who was signing off for the night, and it made a big difference. The stations got a key, so they all tried to do it late at night. Then they followed it over to who had the first 15-minute interview on the late night shows.
Yeah.
Because people usually flush, turned it off, went back to sleep. And the late night shows are important because when you turn on your morning TV, that's the channel you're going to keep on watching. So it's a real. Oh, you
No,
could?
can you summarize for us?
I don't know, Alan, you want?
No, back in the 90s, the public health in New York City realized sanitation that when different TV stations had on the weather for the night at different times, there was a certain amount of flushing each point. So they figured out this channel is going off the air. Oh, that's the one who's doing all the flushing and went all the way through. So everybody moved to the end of the night. And then they went into the late night and realized after the 15-minute segment, whoever ended first got the most flushes. And that's important to the TV station because when you shut off your TV at night, that's the same station turning on in the morning. What's all linked together?
That might be a good lead into this, because the other thing that we've been very interested in, and there was a group in Chicago doing this, I haven't seen, I was looking for them to be active, they're not right now. And in addition to infectious tracking, they can also track, yeah, I'm done, yeah. This is the last slide, medications. So medications can also be tracked. And you know, these guys found like metabolites of antidepressants and illicit drugs and all kinds of stuff, all from wastewater. So that really is it. The big picture is that what goes into health today, when I see you in clinic, I only see a very narrow exposure, the very tip of the iceberg, but there's all of this other thing that happens to you in your life, the 99% of the time you're not in front of me in clinic. That is what likely has the biggest impact on health. And that is why I'm here, is I like to find people who are willing to, or interested in the health outcomes of individuals and how it ties back to environment, and in this case, to water. So that's it. I will be happy to entertain questions, and definitely happy to entertain like future collaborations.